Post-resuscitation care. 1. Stabilization. ETT placement. Keep SBP greater than 90 mm of mercury. MAP greater than 65. O2 sat 92 to 98%. PaCO2 35 to 45 mm of mercury. Glucose 150 to 180 mg per deciliter. 1. 12-lead ECG emergent cardiac intervention STEMI. Unstable cardiogenic shock. Need mechanical circulatory support. 1. In comatose, not ordered. TTM, CT brain, EEG monitoring, and critical care Middlesex. Monitor core temp. Maintain normoxia, normocapnia, euglycemia, lung protective ventilation. Targeted temperature management. 1. TTM is recommended for all patients who are unable to follow orders. 1. The goal is to keep the temperature constant between 32 to 36 OC for at least 24 hours. 1. Prevention of fever in patients when TTM is discontinued. 1. Rapid infusion of IV cold fluid is not recommended in the pre-hospital setting. PCI after cardiac arrest. 1. Emergent coronary angiography in all cases with suspected cardiac cause and ECG with STE and considered in suspected cases. 1. Electrically or hemodynamically unstable. OHCA plus comatose plus cardiac origin STE. Neuroprognostication. 1. Neurological forecasting should use a combination of assessments. 1. And wait for enough time to avoid drug effects or during the early post-injury period. 1. In patients undergoing TTM, the prognostic time is usually at least 5 days after ROSC, 72H after normothermia, with minimal interference from sedation. Recovery. 1. Surviving patients, and their relatives, require assessment, emotional, cognitive, physical, neurologic, cardiopulmonary, and systematic care, cardiac rehab, physical, occupational, speech therapy, and social reintegration recommendations. 1. Such as driving, having sex. 1. Analyze and summarize teamwork, including acknowledging the emotional problems that may arise with the team in caring for this group of patients. Specific circumstances of resuscitation. 1. Accidental hypothermia, see hypothermia, rewarming, including extracorporeal rewarming, with standard resuscitation is not considered fatal until rewarming unless there is an obvious mortality. 1. Anaphylaxis, see anaphylaxis, administer standard resuscitation with an emphasis on epinephrine. 1. Asthma. In patients with sudden increase in PIP or difficult ventilation, tension pneumothorax is suspected. Consider reducing RR and tidal volume, increased I.E., to reduce the risk of auto-PEEP and barotrauma. During peri-arrest, if auto-PEEP increases or BP decreases, disconnect from bag mask or ventilator and apply chest wall compression to reduce air trapping. 1. Cardiac surgery. In post-cardiac surgery with VT, VF, perform defibrillation 3 consecutive times, if not successful within 1 minute, then start CPR. 1. In post-cardiac surgery with asystole or bradycardic arrest with a pacer wire, perform pacing, if unsuccessful within 1 minute, initiate CPR. 2. Consider resternotomy for post-cardiac surgery within 10 days. 3. Open chest CPR during or shortly after surgery. 4. In patients who do not respond to standard treatment, ECMO or cardiopulmonary bypass may be performed. 1. Drowning. Perform CPR with rescue breathing by resuscitation as soon as possible. 1. Mouth-to-mouth ventilation may be performed in the water. 1. And all who received resuscitation, refer to hospital for observation for at least 4 to 6 hours. Cervical spine stabilization is not recommended as a routine. 1. Electrolyte abnormality. Hyperkalemia. IV calcium. 10% CaCl2 5-10 ml or 10% Ca gluconate 15 to 30 ml IV over 2 to 5 minutes. Sodium bicarbonate 50 MEq IV over 5 minutes. Mixed 50 grams glucose plus Ri10 IU IV over 15. -30 minutes. Nebulized albuterol 10 to 20 mg over 15 minutes. Emergent hemodialysis. Kayexalate is not recommended. Hypomagnesemia. MGS 041-2 grams plus 5 dW 50 to 100 ml Sig IV over 15 minutes cardiac arrest plus QT prolongation. Hypermagnesemia. IV calcium. Hypokalemia. KCLIV 2 MEQ, min then 10 MEQ over 5 to 10 minutes. Life-threatening hypokalemia. 1. Opioid overdose. Naloxone 0.4 to 2 mg IV Q 2 to 3 minutes. 1. Pregnancy. See pregnancy resuscitation. 1. Pulmonary embolism. In diagnosed cases, thrombolysis. Alteplase 100 mg IV bolus or IV over 15 minutes or 50 mg IV bolus, then 50 mg IV over 2. 1. H. Or surgical embolectomy or mechanical embolectomy. In suspected PE cardiac arrest, thrombolysis is considered. 1. BZD overdose. Flamazanil is not recommended in undifferentiated coma. 1. Beta-adrenergic blocker overdose. Refractory shock high-dose insulin. Rhode Island 1 U per kilogram IV bolus, then 1 U kilogram per hour plus 50% glucose 50 to 100 milliliters, then drip. 0.5 grams kilogram per hour. Monitor glucose Q 15 to 30 minutes. Hemodynamic response 30 to 60 glucagon 5 mg IV over 1 minute, 10 to 15. Then drip 2 to 5 mg per hour. Keep MAP greater than 60 mm of mercury or consider giving calcium or doing ECMO. 1. CCB overdose. Refractory shock 10% calcium gluconate 30 to 60 ml IV over 10 minutes. Repeat Q 20 minutes up to 4 times high-dose insulin. 1 U per kilogram bolus, then 1 U kilogram per hour. Plus glucose or consider giving IV glucagon or doing ECMO. 1. Cocaine-induced HT, agitation, chest discomfort. BZD, alpha blocker. CCB, NTG. Morphine avoid beta-adrenergic blocker. 1. Local anesthetic. Neurotoxicity cardiac arrest bupivacaine toxicity lipid emulsion 1.5 ml per kilogram IV. Max 100 mg. Over 2 to 3 minutes, repeat as need. Then drip 0.25 ml per kilogram, min. 1. Sodium channel blocker. TCA. Sodium bicarbonate 1 to 2 MEQ per kilogram IV over 1 to 2 minutes cardiac arrest or cardiac conduction delay. QRS greater than 120 milliseconds. Repeat until stable. Narrow QRS. Then sodium bicarbonate 150 MEQ plus 5 dW1L drip rate 150 milliliters per hour. Keep serum pH 7.45 to 7.55 or consider ECMO. 1. Digoxin toxicity. Antidigoxin Fab severe cardiac glycoside toxicity. 1. CO poisoning. Hyperbaric oxygen therapy severe toxicity. 1. Cyanide. Hydroxycobalamin 5 grams IV over 15 minutes. Repeat 5 grams IV over 15 minutes 2H. Plus 100% oxygen plus or minus sodium thiosulfate 12.5 grams IV. Repeat half. Thank you for watching. Please click subscribe for new videos.